यहाँ पे 2 सेल पड़े हुए तो हैं, मुझे नहीं पता वो यूज है कि पूछू क्या इनसे, रुको इनसे पूछू ये वाले सेल है क्या, रुको पूछती हूँ। यहाँ 2 सेल पड़े हुए हैं भारी। Hello everyone, I'm Dr. Divya Gupta, your original guru for periodontics, and I hope you all solved all the questions of TND and saw the explanations. I got few doubts after you all saw the videos, the discussion of TND. I hope most of the things were clear, and here today we will be discussing the doubts which we got from the students. 5 to 6 doubts are there that we would be clarifying, and other than that, if you have any doubts in any other topic, let us know in the comment section, or you can ask us the questions in the Telegram group directly, and we will be there to help you out. Okay, so let us start with the session of Ask Me Anything. The first doubt which I got was sulcus depth around dental implants. Okay, so sulcus depth around dental implants, the anatomy of dental implants compared to the natural tooth is completely different. So first of all, let us see what is the anatomy, how is the tissue, the bone around the implant formed. Okay, so this is the picture. In this image, you can see on this side there is natural tooth, and on the other side they have shown the image of a dental implant, the integration of an implant to the bone, and how the gingival fibers are forming around the implant. So we all know that how the tooth is anchored in the inside the bone. It is anchored with the help of a periodontal ligament. So the tooth is mobile. It is not firm, right? It is mobile. So the periodontal ligaments which are present between the tooth and the bone helps in the anchorage of the tooth, and they help in the mobility of the tooth. They are not fixed. They show some mobility always. Because of that only orthodontic movements and other movements are possible. But that is not the case in implants. In dental implants, the connection between the implant, this connection between the screws of the implants and the bone is firm. It is a tight junction. It is a tight osseointegration. If there is a fibrous integration, which is called as fibrointegration, then the implant will not be firm inside the bone, and there will be mobility. We will need to remove the implant. It will not be anchored inside the bone. Okay, so what we want inside the bone is an osseointegration with the implant, so that there will be a firm anchorage and it will be able to bear the forces of the tooth. Now let us talk about the soft tissue around the implant and the tooth. The soft tissue, the fibers which are here, the gingival fibers, the dentogingival unit around the tooth. Here you can see this is the dentogingival unit. The dentogingival unit around the tooth consists of junctional epithelium plus gingival fibers, right? This. So here you can see that the gingival fibers, this is the junctional epithelium. This is the junctional epithelium, and this is the gingival fibers. The gingival fibers around the tooth are perpendicular to the tooth, most of them. Some are circular fibers which surround the tooth. Some are parallel fibers in the interdental area, but most of them are perpendicular to the tooth. Okay. But in case of implants, the fibers are not perpendicular. The collagen fibers, the gingival fibers, they are not perpendicular. They are parallel to the tooth, like this here. So the connection, it is not that much firm. The connection between the gingiva and implant is not that much firm like it is in the case of natural tooth. Thus, the probing depth, as the tooth is firmly, as the gingiva is anchored to the tooth firmly at the junctional epithelium, here the connection is tight, right? It is tight. So the probing depth in tooth is 2 to 3 mm, normal probing depth. I am talking about normal probing depth. But in cases of implants, here this connection is loose and the probe will penetrate right up till the alveolar crest most of the times. Okay, so in such cases, in implants, the probing depth is normally 3 to 4.5 or 5 mm, you can say. Normally it is up till here. Okay, so let us see the difference. I hope this connection, the junctions that are present between the implant and the tooth is clear by this image. The anchorage is with the help of directly with the bone in case of implants, and here PDL is present, which is a soft tissue. Thus the tooth is mobile, shows some mobility. Okay, so let us see the difference between the tooth and the implant. The difference between the tooth and implants. So with probing depth, the probing depth in case of tooth is this. You can write it down, guys, or just take a screenshot after I complete, because this is important. Probing depth is asked in the exam. So probing depth around the tooth is 2 to 3 mm and around the implants it is 3 to 5 mm. Okay, now the connective tissue attachment is, in the connective tissue around the tooth there is less collagen and more fibroblasts. But in case of implants, the fibroblasts are less compared to that of the natural tooth. So here there will be increased collagen and less fibroblasts. The vascular supply. The vascular supply in case of tooth is more and it is less in case of implants. Okay, it is less compared to that of natural tooth. Here the PDL is present, here it is absent. The connective tissue fibers or the gingival fibers here, they are arranged perpendicular to tooth. And here they are parallel to the tooth. They are parallel to the tooth. Okay, so these are the few differences which you will see between the tooth and the dental implants. In this, guys, the pocket depth, this is important for you all to remember for MCQ purposes. Okay, so I hope now it is clear that the sulcus depth around the dental implant is 3 to 5 mm. Okay, or you can say 2.5 to 4.5 mm, but it will be in this range only. Okay, now let us see the second doubt. The second doubt is images of various flap surgeries. So this I have discussed many times in the recorded sessions. I have shown my own cases. I will be showing my cases here also. And guys, in our Telegram group, I will be sharing 2 videos today. One is of modified Wiedemann flap and the other is of coronary displaced flap. Okay, so see those 2 videos, you will be more clear. They are animated videos. Because of time constraint, I'll not be able to show it here, but see those videos. It will be more clear, when you will see the videos, when you will see what is happening in flap surgeries in a 3-dimensional view, it will be more clearer to you. And after that, after seeing those videos in the Telegram group, if you have any doubts, you can ask me. Okay, now I will be showing you the images and I'll try my level best to explain it to you, because flap surgeries are such a thing that you have never seen in your graduation. In our undergraduation, we have never seen any only few students will be going and watching perio surgeries when the PGs are doing it, right? So we are not that much clear what is happening in flap surgeries. Thus, I'll explain it to you, and this is a bit difficult to visualize for you all. So just ask me in the Telegram group or in the YouTube, but sorry, in this comment section. But the videos I will be posting in Telegram group today. So just go and have a look there. It will be more clearer for you. Okay. So now let us see the classification of the flaps. So the flaps are classified based on the bone exposure, whether the bone is exposed and or whether it is not exposed. So just think for a minute, when will the bone be exposed? When we will raise whole of the gingiva, right? When we will be raising whole of the gingiva. So sorry. So if this is the gingiva, this is the tooth, here is the gingiva, this is the bone, right? Bone. Now what we are doing when we are why we are doing flaps, why we are raising flaps, guys? We are raising the flaps because we can visualize what is there below the gingiva. When we will be able to visualize it, we will be able to treat it, right? So when I am removing this flap, when I am removing this flap, what I am able to visualize, what I am able to see? Directly the bone, right? Here bone. And what I want to see in the bone, what I want to visualize on the bone, the calculus which is here. Whatever calculus is here, I want to see that so that I can easily remove it. Another thing what I will be seeing is the bone, right? After exposing the bone, after raising a full thickness bone, if I am raising a full thickness bone, whole of this flap, I am removing, I am elevating. What I will be seeing? The bone, right? Why I want to see the bone? So that I can treat the defect which is present either by osteotomy or osseous regenerative surgeries. Okay. See, in this limited time period, I'll not be able to explain you all the things like what is there in regeneration, what is there in resective surgeries. Okay. I hope you all know by now that what is the difference between resection and regeneration. So whenever I'll see a defect here, if there is a defect that is present here, so this defect I will be able to fill only after raising this whole flap. So to visualize the bone, to visualize the tooth, I need to raise the full thickness flap. Full thickness flap means it consists of, full thickness flap consists of the periosteum and the connective tissue and epithelium. So it consists of epithelium plus connective tissue plus periosteum. We have to remove whole of the periosteum. If this whole of the periosteum will not be removed, there will be severe bleeding. Okay, so see here, I have raised in this picture, you can see that whole of this flap is being raised. Now we can directly visualize the bone. This tissue will be removed with the help of curette or by cutting. We can remove this tissue. So we will be able to see the tooth here. We will be able to see the bone and do the treatment accordingly. In partial thickness flap, what we are raising? We are just raising the epithelium, this epithelium and a part of connective tissue and a part of connective tissue. So here I'm not raising the periosteum. So what I'm not able to see, I'll not be able to see the tooth structure and the bone which is lying beneath the flap, beneath the gingiva. I'll not able to visualize, right? So here you can see that whatever structure is lying below this gingiva, I'm not able to see that. So why I need to raise this partial thickness flap? Most of the times this partial thickness flap is raised in cases of recession when I want to do the root coverages. In recession cases, we need to go for a partial thickness flap. Okay. So this is the full thickness and the partial thickness flap. I hope it is clear. Now based on the placement of flap. So the flap, so here we have elevated the flap. This flap was elevated. Now we need to place it back. If this flap is stitched to its original position, if it is stitched here, if it is stitched back to its original position, it is an undisplaced flap. So flap stitched to its original position is undisplaced flap. But Sometimes what we do is we do osseous resection. We remove some part of this bone. Like in the cases of crown lengthening, we remove this much part of the bone. We do ostectomy and we displace this flap apically. Right? We are displacing the flap, or we can shift the flap coronally, or we can shift the flap laterally, as in the cases of recession coverages. We shift the flap coronally, we move the flap laterally, okay, where we are raising a partial thickness flap. In such cases, it is called as the displaced flap, when the flap is not stitched to its original position. Okay. Now, let us see the examples of undisplaced and displaced flaps. So, undisplaced flaps are Wiedemann flap. This was the first flap that came into existence, that was given by Wiedemann. Okay. Then came the modified Wiedemann flap and the Kirkland flap. In periodontics, guys, most commonly we are using this Kirkland flap. This Kirkland flap is also known as envelope flap. Or this procedure is also known as modified Wiedemann flap. Sorry, modified flap operation. Modified flap operation. In this case, only clavicular incision is given. Only clavicular incision is given, and this is the most commonly used flap in periodontics. Most commonly used flap in periodontics. Displaced flaps most commonly are used in apically displaced flap is used in crown lengthening procedures. It is used in crown lengthening procedures where we are displacing the flap. We are moving the gingiva. We are moving the gums in the apical direction. When we are moving the gums in the coronal direction or in the lateral direction, it is called as coronally displaced flap or laterally displaced flap, right? So just think for a minute that apically displaced we are using in crown lengthening procedures commonly. Coronally and laterally displaced flaps, when we will be using them, when we need to cover some area, and in the gums we need coverage for recession. So most commonly they are used in recession cases. Okay, recession coverage. So now let us see. And finally, the third type of classification is management based on the management of papilla, whether we are preserving the papilla or we are cutting the papilla. If we are cutting the papilla, then it is a conventional flap. And when we are preserving the flap, when we are not cutting the papilla, we are preserving this interdental papilla, then it is called as papillary preservation flap. Okay, now let us see one by one all the procedures which we studied previously. So number one, the first flap that was developed was Wiedemann flap or the original Wiedemann flap. It was given by Leonard William. It was given by Leonard Wiedemann. Now in this case, guys, what we are doing, this flap was first came into existence. Why we used this flap? To remove the infected pocket epithelium. Remove infected pocket epithelium. So here, this is the tooth. Here, this is the sulcus or periodontitis affected patient or tooth. This is the bone. Okay. Now, previously it was thought that when we remove this part which is infected, here there is bacteria, all of this is bacteria, okay. If we remove this much part which is there, this infected pocket, infected by bacteria, and we remove whole of this dental plaque, we will be able to save the tooth from loosening, or we will be protecting the tooth. So previously it was thought like that in the ancient times. So the main concentration was to remove the pocket epithelium. So in such case, what they did was did an internal bevel incision. They gave the internal bevel incision up till the alveolar crest. Wait. So first they gave the internal bevel incision like this up till the alveolar crest. This is the internal bevel incision. External bevel incision is like this, which is used in gingivectomy procedures. This is the internal bevel incision. Next, the second type of incision that was used was the crevicular incision. Why it is called as crevicular incision? It is called as crevicular incision because we go from the crevice, we go from the sulcus. So between the teeth here, the sulcus is there. Okay, here sulcus, sulcular space is there. So we go from the sulcus till the alveolar crest like this. So this is called as the crevicular incision, and thus we removed whole of this like this, and whatever wedge of tissue, this wedge of tissue which is attached here, this tissue which is attached here, that is removed by interdental incision. So this is the crevicular incision and this is the interdental incision. Okay, so we remove this wedge of the tissue, but in this case what Leonard Wiedemann did was he gave a vertical incision as well. So the only difference between the Wiedemann flap and the modified Wiedemann flap, so you must remember whatever the modification is came afterwards, right? So the Wiedemann flap used vertical incisions, while the modified Wiedemann flap no vertical incisions. Okay, vertical incisions were not used. Otherwise, all the three incisions, the crevicular incisions, the internal bevel incision and the interdental incision, all three incisions were used in the modified Wiedemann flap other than vertical incision. So vertical incisions were not used. Vertical incisions were used in Wiedemann flap. The disadvantage of using a vertical incision is we are creating extra trauma to the tissue. We don't need this incision. We can just elevate the flap. We can just separate it from the periosteum and treat the underlying conditions. But here we are giving an extra trauma to the gingiva, which will take time to heal. It will heal with scarring. So we need not give vertical incisions in periodontics unless and until we are doing any periapical surgeries, right? We need not give them. So this is the Wiedemann flap. And in the modified Wiedemann flap, all the three incisions, the horizontal incisions are all the three horizontal incisions. I hope you know. We have already discussed the horizontal incisions are internal bevel incision, crevicular incision and interdental incision. All these three are horizontal incisions. All these three horizontal incisions are used and we remove the pocket lining. So when the incision is given below the gingival margin, it is given 1 to 1.5 to 0.5 to 1 mm below the gingival margin. So we give the incision like this. This incision which I am giving is the internal bevel incision. Then what we will do is, so this internal bevel incision, this is the internal bevel incision. Next we give the crevicular incision. The crevicular incision is from the crevice till the alveolar crest. So see here, you can see this where the blade is going inside the crevice, inside the sulcus. I hope it is clear. This is the internal bevel incision and this is the crevicular incision. This is the crevicular incision. The blade you can see is inside the sulcus. You cannot see the tip. It is inside the sulcus. So this is the crevicular incision like this. And lastly, this tissue, this whole of this tissue, this is the inflamed tissue, is removed with the help of interdental incision. This is what is there in the modified Wiedemann flap and the Wiedemann flap. Okay, I hope it is clear. So why we developed modified Wiedemann flap? So that there was less trauma to the tissue. Otherwise, whole of the procedure is similar between the modified Wiedemann and Wiedemann flap. Okay. Now, this is the clinical picture. See here. These two lines, I hope it is clear to you. I'll just zoom it more. Okay. These two lines which you see here. This line. This is the internal bevel incision. It is given 0.5 to 1 mm below the gingival margin, and also you can see the bleeding in the sulcus. This is because of the sulcular incision. So what we have done, we have separated the pocket lining, the infected pocket lining, and after that we are giving the interdental incision. So see here, you can see after both the incisions are given, the internal bevel and the crevicular incision, the flap is elevated. This flap, you can see, this is the elevated flap, right? And here you can see what is this? What is this? This is the inflamed pocket lining which we need to remove. So here you can see the pocket lining is removed. Now we can visualize the bone, the tooth, and we can clean it properly and then suture the flap back. But the disadvantage here, the disadvantage of this technique when we are removing the pocket lining is there is increased chances of root sensitivity, increased chances of root sensitivity because of recession, Now why recession developed? Why there was recession? Why? It was there because we have separated this lining. We have removed a part of gums. We have removed a part of gingiva, right? We have removed it. If this is the tooth, we have removed this much part and then we are suturing back. So what we have created? We have created a recession. So there are chances of developing sensitivity. There are chances of developing root caries. So because of this drawback, we shifted to Kirkland flap. Which was less traumatic. Later it was identified that we need not remove the infected epithelial. We just need to clean it. We just need to curate it. And after that, there was proper healing. So what was developed was the modified flap operation, or the third flap which was developed was the modified flap operation, or the Kirkland flap. The Kirkland flap. Okay, so in this Kirkland flap, you need to remember only one thing. No internal bevel incision was given, no interdental incision was given, and no vertical incision was given. Right? Only crevicular incision was given. Only crevicular incision was given. By giving the crevicular incision, so here you can see that the blade is inside the sulcus. So if this is the tooth, so incision was given. The incision was given here only. Internal bevel incision was not given. Interdental incision was not given. So in this, what we have done is, we are not removing the pocket lining. We are not removing a part of gingiva. But we are elevating the flap so that we can visualize the calculus, we can visualize the plaque, and we can remove it. So by elevating the flap, here we are just elevating the flap from the periosteum. A full thickness flap is raised. We can visualize whatever calculus is here, whatever bone defect is there, and we can treat it accordingly. So here you can see that after measuring a pocket, crevicular incision is given in this region, in this part, crevicular incision is given. The flap is elevated. So the flap is elevated. We can visualize the bone, whatever calculus and defect. Here you can see that there is grade 2 furcation involvement. We can visualize it. We can do odontoplasty, osteoplasty according to our diagnosis. We can suture back the flap. Okay, we can suture it back. So here the advantage is only single incision was given, so there is less trauma. Very minimal recession, minimal or no recession actually. Okay, so this is the advantage of using a Kirkland flap, which is also called as modified flap operation or the envelope flap. Now let us come to the displaced flaps. There are three displaced flap, which is the apically repositioned flap, the laterally and the coronally displaced flap. Apically positioned flap we have already studied, most commonly is used in cases of crown lengthening, right? So in the apically displaced flap, what is done? We are shifting the gingiva in the apical direction, right? So here, this apically repositioned flap, this is important, you must know it. It was given by Neighbors. It was introduced by Neighbors in the year 1954, and the term apically repositioned, the term was coined by Friedman in the year 1962. So here you can see in apically repositioned flap, crevicular incision is given, but in apically repositioned flap, what we are doing is we are shifting the apica, we are shifting the gingiva apically. So how can we shift the gingiva if we are not giving the vertical incision, right? So we need to give the vertical incision in cases of shifting the gingiva apically, coronally or laterally. Just remember it, we need to give vertical incisions given. ठीक है, थोड़ा सा common sense you need to use in this, that we are shifting it, we are moving the displaced flaps. So we need to give, to move, we have to give vertical incision. Anything we want to move, if we are just giving horizontal incision, the gingiva will not move. So here you can see in this picture that crevicular incision was given and vertical incision was given, and this whole complex of gingiva was shifted apically and it was sutured. So you can see the difference here. The gingiva has shifted apically. Why this gingiva we needed to shift apically? Because this area can become self-cleansing and the patient will be able to maintain an oral hygiene. Okay. Now the papillary preservation flap. In the papillary preservation flap, we are not removing this interdental papilla. Most commonly used in presence of interdental spaces of more than 2 mm, means this distance should be more than 2 mm. Okay. And it is used in cases of aesthetic areas. It is most commonly used. Now what we are doing is we are just giving the crevicular incision. So if this is the buccal side, we are just giving the crevicular incision here and leaving this interdental papilla. In the interdental area, we are not giving any incisions. We are just, so if we see the tooth from the top or from the occlusal aspect, if this is the tooth from the occlusal aspect, what we are doing is like this, around the tooth we are giving the incision. We are not giving incision like this, no, just around the tooth we are giving the crevicular incision. Then we move back on the palatal side, and on the palatal side at a distance of about 4 to 5 mm, a semicircular incision is given. We penetrate up till the depth, up till the periosteum. Then with the help of a curette or with the periosteal elevator, I find periosteal elevator more convenient. It is a personal choice. We just separate the flap from the beneath. So like this, we just separate the flap so that it will be separated from the underlying bone along with the periosteum, and we push it in the anterior aspect, so that whole of this complex is shifted or it is moved anteriorly or buccally, and we are preserving the papilla here. Then whatever surgery needs to be done, we can do it and close the flap. So here in this case, you can see that this is the buccal view. We have given the crevicular incisions here. Crevicular incisions, interdental incisions are not given. Then on the palatal aspect, like this incision. A semicircular incision is given at a distance of 4 to 5 mm. And we just push this papilla. With the push from here, we push this papilla on the buccal aspect, so that like this it will be separated. We can do whatever procedures we want to perform on the bone, on the root surfaces, and we can suture it back. So this is what is the papillary preservation flap. This papillary preservation flap, it was given by Cortellani. This PPF was given by Takai et al. It was given by Takai et al. And it was modified. It was modified by Cortellani. Okay. This you need not remember. This is just a general information. So this was about the periodontal flaps, the various flaps that are used. Mostly they will be asking image-based questions from this topic. In image-based questions, the papillary preservation flap they can ask you, or they can ask you difference between the displaced flap and the undisplaced flap. Okay, so you must know that properly. Now doubt 3 is sling suture image explanation. Okay. The person or the student who wants to know what is the I think mostly he or she saw the image in the Carranza and in the explanation, and you were not able to understand it, right? So I'll just explain it to you, what is sling suture and how to go about it. So one thing you must know is that sling sutures are used in cases where only one flap is raised, means the other flap it is firm. So it is sling suture used when only a single flap means either buccal or lingual flap is raised, right? Okay. So when only a single flap is used, we are using a sling suture. Now, what is a sling? A sling is like an anchor which anchors around the tooth. It is a sling. It is anchoring around a tooth and it is taking the support of a tooth. Okay. So in sling suture, when you will see, so I hope you need an explanation for this image only. If it is anything else and I'm not able to understand your question properly, just let me know in the comment section. So when you will see the sling suture from the above, from the occlusal view, this is what it will look like. So if this is the tooth, right? If this is the tooth from the occlusal aspect, here there is a buccal flap. This is the buccal flap that is raised, and this is the lingual flap which is not raised. It is not raised, so it is intact. So what we need to do is, definitely we need to suture the buccal flap. We need not do any extra injury to the flap which we have not raised. So what we will do is, we will pierce our needle from the buccal side. Here, I will pierce the needle here. Okay. Like this. Here you can see, this is the buccal flap. This is the buccal flap. This is the lingual side. It is not raised. Okay. We pierce the flap from the buccal side like this. Then we don't pierce it on the lingual side. We just go around the tooth like this. Like this. And we again pierce it from the buccal side. So what we are doing is, we are surrounding it like this, going into the interdental space. This is the interdental space, the space between the two teeth. We are bringing it on the buccal side, and then again from the buccal aspect we are piercing the needle. So brought the needle back on the buccal side and piercing it here again. Okay, we are piercing it back here, and again from here, without touching the lingual flap, we are encircling the tooth, coming back here and tying a knot here. Sorry. Tying, E-I-N-G, a knot here. Okay. Here we have tied a knot. Okay. So like this is what? This is like the tooth is here and is acting like an anchor, and the thread is like a sling. So this is the sling suture. We have tied the knot here on the aspect here, this. Here we have again brought it back from here till here, and a knot is tied here. Knot is tied here. So I hope it is clear now what is a sling suture and when it is used. Okay. Now I had two similar doubts in which the explanation was similar. So one doubt was important bacteria to remember and the trick to remember them. Right. You need not remember everything, all the bacteria which are present into the dental plaque, or all the bacteria, all the primary, secondary colonizers. You need not remember. Only important bacteria you need to remember. I have formed some mnemonics for some complexes, and just I have tried to make it simple for you all to remember important bacteria, not all the bacteria. Okay, important bacteria you can easily remember by this trick. And the fifth doubt was microorganisms of biofilm, means the person wants to know, the student wants to know which are the microorganisms which are present into the biofilm, who are primary colonizers and secondary colonizers. You also need to know how you need to remember the primary and secondary colonizers, right? So this diagram we have seen 100 times now. This diagram was given by Sokransky. So how you will remember the name of the complexes, the colors of the complexes, right? So the primary colonizers, there is primary colonizers. The primary colonizers are present. The primary colonizers are the initial bacteria which are colonizing the tooth. These are the first bacteria which attach themselves to the pellicle, right? So the first bacteria which are coming in contact with the tooth are aerobic or facultative anaerobic bacteria. So what are aerobic and facultative anaerobic bacteria? These are the bacteria which can survive in the presence of oxygen. They utilize the oxygen which is present around the tooth, right? And mostly they are cocci. They are round in shape. Most of the bacteria in the primary colonizers are round in shape. They are cocci. So round shape bacteria are Streptococcus or Actinomyces. Actinomyces bacteria is also round in shape. So these two belong to the primary colonizers group. And the complexes of bacteria which are formed by them are yellow complex and purple complex. Okay. So here there are two complexes, yellow and purple. Now one thing you need to know is Actinomyces is a species, right? Aggregatibacter is a species. Streptococcus is a species, and the strain is Mitis oralis sanguis. Actinomyces, Aggregatibacter Actinomycetum comitans has A to F strain. There are 6 strains. Okay. So the species Actinomyces is a species. So what happened was, I hope you all know what how these complexes were developed. So Kransky, what he did was he studied 185. He studied 185 subjects, 185 individuals, the plaque of 185 individuals, and approximately 13,000 plaque samples he studied under the microscope. 13,000, just imagine the number. And he found certain bacteria were found together more commonly than the other bacteria. So there was a cluster of organisms which were recovered together. Okay. But there was one strain, one exception, which was, sometimes found with, no cluster, means it was found neither with the orange complex, neither with the green complex or yellow complex. And sometimes it was found with clustered with other organisms. That species, that exception was, the exception was Actinomyces. So Actinomyces is an independent species. Independent species. It is found with purple complex, blue complex. It is found with green complex. It is found in gray complex. This outer white thing you can see is the gray complex. So in gray complex you will see two strains, Actinomyces strain B. Actinomyces strain B and Streptococcus noxia. Not important. You need not remember this. Streptococcus noxia is not important. Gray complex में one bacteria is there, which is important is Actinomyces, which is strain B. This is easy to remember. Okay. In purple complex, there is Actinomyces and Vollinella species. AV. In purple, there is AV, audio visual effects. Actinomyces and Vollinella. These two you can remember, AV, audio visual effects. Okay. In yellow complex, there is only Streptococcus species. There is only Streptococcus. So if they are asking you that which organism, which amongst this is not a bacteria of yellow complex, anything other than Streptococcus will be the bacteria, will be the answer, right? So you need to remember only the Streptococcus term, the Streptococcus species. You need not remember the name of strain, which is the Mitis, Oralis, Sanguis, Gordoni, Intermedius. No, you need not remember it. But one exception you need to remember here is Streptococcus constellatus. This is a Streptococcus species which is present in orange complex. The only Streptococcus species which is present in orange complex is Streptococcus constellatus. So one name you need to remember is constellatus. Okay. So they can give you the options like which amongst these is not a primary colonizer, and the options are Streptococcus mitis, Streptococcus oralis, Streptococcus sanguis and Streptococcus constellatus. The answer will be Streptococcus constellatus. Important, you need to know this. This is important. This can be asked in MCQs, guys. Okay. So primary colonizers, I hope it is clear now. The purple complex and the yellow complex. Now let us move to the secondary colonizers. The secondary colonizers. How you will remember the secondary colonizers? You need to remember the traffic signal lights. That's it. सबको traffic signals की light पता है. All of you will be knowing what are the three different lights in the traffic signals, which are, they are green, orange and red, right? They are green, orange and red, right? Now we know the meaning also of what these lights mean. Green means everything is okay, you can go, you can proceed further, you need not stop. Orange means there is some sort of danger and you need to be cautious, you need to slow down. And red means stop, there is danger, you need to stop now, right? Now let us see how you will remember the green complex bacteria. So in green complex you need to remember the mnemonic ACE. The mnemonic which you need to remember is the ACE. So here ACE means from A there is Actinomyces. Actinomyces species strain A. And this is the strain that is important. This is the strain A which is causing aggressive periodontitis. Most important strain A. Okay, you need not, agar B strain if you don't remember, it's okay, but strain A you need to remember. Strain A is present in green complex. Next is Echinella corrodens. Sorry, C. From C it is Capnocytophaga species. Capnocytophaga species. Now guys, you need not remember the names of Capnocytophaga, Gingivalis, Putigena, Ocratia. No, you need not remember it. Only one thing you need to remember is C for Capnocytophaga, A में C is Capnocytophaga and E is Echinella corrodens. Echinella corrodens. Okay, this much only you need to remember. And green complex is a complex which is important. So up till here, this whole complex is composed of good bacteria. It is composed of good bacteria, or you can say beneficial organisms, beneficial to the periodontal health, beneficial to periodontal health. Okay, the yellow complex, the purple complex and green complex are good bacteria. They are composed of good bacteria. You need not remember all the names. Just for green complex, you need to remember ACE, the mnemonic ACE. A for strain A of Actinobacillus actinomycetum comitans, E for Echinella corrodens, and C for Capnocytophaga species. That's it. Okay. Now let us come to the orange complex. The orange complex is a very interesting complex. The orange complex is a very interesting complex. Why? Because it consists of bridging bacteria. It consists of bridging bacteria, the bacteria which acts as a bridge between the good bacteria and the bad bacteria. These are the danger bacteria. This is the dangerous bacteria and these are the good bacteria, and it acts as the bridge. This is a bridge. So the bacteria which are present in the orange complex are bridging bacteria. Okay, they are bridging bacteria and they are present into the periodontal pocket. Present in perio pocket. Mostly they consist of rods and spirochetes, right? So they are present in periodontal pockets. So good bacteria are present onto the tooth. Orange complex bacteria are present into the pocket, and bad bacteria or the dangerous bacteria are present into the epithelium, on the pocket epithelium. This you need to remember. Okay, so this bridging bacteria, this orange complex, it consists of Fusobacterium nucleatum. It consists of Fusobacterium nucleatum. Okay, then it consists of Campylobacter species. Campylobacter species. And another important bacteria which it consists of is the Prevotella intermedia. Prevotella intermedia is the bacteria which increases in pregnancy. Increases in pregnancy or in conditions of stress. Why? Because it derives its source of nutrition from cortisol. Source of nutrition is cortisol. Okay, so in the conditions where cortisol increases, this bacteria also increases. So Fusobacterium nucleatum, Campylobacter and Prevotella intermedia. These are the three bacteria which are bridging bacteria which are present in the orange complex, which are present into the pockets. Okay. Now lastly, the danger group, which is the red complex bacteria. The red complex bacteria or the dangerous group. The red complex consists of PTT. PTT is prothrombin, right? Here, another way to remember is, so this is Porphyromonas gingivalis. This complex is present onto the pocket epithelium. This complex is responsible for bleeding on probing. So anything which is related to red is in the red complex, in the danger complex. Okay. So porphyrin ring is present. Porphyrin is a protein. It is a ring that is present in hemoglobin, and hemoglobin is red in color. It is present in the RBCs, right? So porphyrin. So porphyrin, so you need to remember Porphyromonas, which is a bacteria present in red complex. Then There is Tannerella. Tannerella forsythus. So how you will remember Tannerella? Tanning means redness, burning, right? Redness. So this is how you can remember Tannerella forsythus. Then is Treponema denticola. Treponema denticola. So here you need to remember trip. This trip. When we trip or when we fall, we get injured and there is redness that is developing. So this is how you can remember the red complex bacteria. Okay. So I hope now it is clear how, you need to remember the bacteria. The important bacteria you need to remember is the red complex bacteria. Here you need to remember the exception, the Streptococcus constellatus. Here you need to remember the pneumonic ACE. ACE. Okay, bridging bacteria में 3 bacteria species you need to remember is Prevotella intermedia, easy to remember. Prevotella pregnancy से related है. Then Campylobacter rectus and Fusobacterium nucleatum. And danger bacteria, I think danger bacteria or red complex, it is much easier for you all now to remember. Okay. Now the next doubt. Let us go to the next doubt. Doubt number 6. Clinical symptoms of gingivitis develop within 2 to 3 weeks, right? I'll show you the table also. So clinical symptoms, here they have asked clinical symptoms of gingivitis develop within 2 to 3 weeks. If in option, there are only means if in an option they have given 1 week, 2 week, 3 week, 4 weeks. So what we need to choose? So in this case, you need to choose option this, 2 weeks. Okay, so now let us see this table or this chart. So here, just take a picture of this, guys. In this, the stages of gingivitis, there are 3 stages of gingivitis and there are 4 stages of periodontitis. Stages of gingivitis are initial lesion, early lesion and established lesion. And stages of periodontitis are initial lesion, early lesion, established lesion, plus there is a 4th stage which is advanced lesion, right? Advanced lesion. Now, in the initial lesion develops in 2 to 4 days, and what changes you will be seeing is there is initial signs of inflammation, there is increase in the vascularization, there is increase in vascular permeability, there is vasodilation. Okay, and the first cells in acute cases, which are the first defense cells that come into action is the PMNS, the neutrophils, the polymorphoneutrophils, right? So the predominant cells in the first stage are the PMNS cells, and they will be increased in the GCF flow. GCF flow is a sign. It is a kind of sign. I'll not say it a sign also because it is not easily, we cannot measure it or we cannot see it clinically that common, right? So you will just see an increase in the GCF flow in first 2 to 4 days. Now in the early lesion, which develops in 4 to 7 days, there will be vascularization, same as stage 1. There will be atrophic areas, there will be ulceration, ready pack formation, but the predominant cells which will be there will be the lymphocytes, the T cells, lymphocytes or the T cells. And if some of you will be having doubt whether in exams if they have given lymphocytes and T cells, what if both the options are given, that they have given lymphocytes also and they have given T cells also, so what we need to choose? So you need to choose the lymphocytes because this is how they have given in Carranza. You need to choose the lymphocytes. There is increased loss around the infiltrate and there is erythema and bleeding on probing seen. Bleeding on probing is not a symptom, it is a sign. It is the first clinical sign that we observe in first week. So in 1 week, the clinical sign that we first see is the bleeding on probing, and the symptoms start developing in 14 to 21 days. Most commonly from second week, you will see changes into the color. What are the symptoms? Symptoms are there is redness, there is loss of stippling, there is slight edema of the gingiva, right? These are the symptoms which the patient might complain that I have swollen gingiva or I have this reddened gingiva in some areas. These are the complaints of the patients, the symptoms of the patients, right? So you will see changes in the color, the size, the texture that will be evident in 2 to 3 weeks time. If they have given 2 weeks and 3 weeks separately, then the answer will be 2 weeks. 2 weeks more preferable than 3 weeks. Okay. And if they have asked you about the clinical sign, the clinical sign or the bleeding on probing is first visualized in the first week. So the answer will be 1 week. One more MCQ we need to cover in this is the plasma cells. They can ask in the same, the which cells predominate in established lesion, whether they are plasma cells, and they can also give in the options B cells. So if both the options are given, if option A is plasma cells and option B is B cells, then you need to choose the plasma cells and not B cells. But if plasma cells is not there in the option, then you need to choose the B cells. Okay. So now I hope guys most of your doubts are clear, and if you still have any doubts, post it in the Telegram group or in the comment section. I'll be more than happy to answer. And guys, soon after we this live session is over, I will be sending the link to the 2 videos which I told you to see for periodontal surgeries in the Telegram group, in our Telegram group of DBMC MDS official. There you can just go see those videos, and if you have any doubts, ask in the Telegram group in itself. Okay, so thank you so much and good night. Study hard, work hard, and keep going. Bye guys.